Today, we are reporting from the 2020 ESMO Virtual Congress. We have recapped some of the top news that have been presented during the conference, and very soon we'll speak with Dr. Priyanka Sharma on some significant studies in breast cancer, and also with Dr. Yelena Janjigian on pivotal data in gastrointestinal cancers. Welcome to OncLive News Network. I'm Gina Morrow. In prostate cancer, ipasertib combined with abiraterone acetate plus prednisone led to a significantly superior radiographic progression-free survival and anti-tumor activity compared with placebo plus abiraterone and prednisone in patients with metastatic castration-resistant prostate cancer with PTEN loss, according to results of a primary analysis from the Phase 3 Potential 150 trial. The addition of neoadjuvant atezolizumab to nab-paclitaxel plus doxorubicin and cyclophosphamide significantly improved pathologic complete responses in patients with stage 2-3 triple-negative breast cancer compared with placebo plus chemotherapy, according to data from the Phase 3 Impassioned O31 trial. Post-operative radiotherapy was linked with a non-statistically significant increase in disease-free survival in patients with completely resected stage 2 AN2 non-small cell lung cancer, and thus cannot be recommended as a standard of care for this population, according to results from the Phase 3 Lung-ART trial. Long-term follow-up of patients with locally advanced or metastatic urothelial carcinoma treated with enfortumab vedotin monotherapy showed encouraging results, with half of patients still alive at 12 months and approximately one-third of patients were alive at 18 months. BLU 945, an investigational precision therapy, elicited robust anti-tumor activity in multiple preclinical models of triple-mutated EGFR-positive non-small cell lung cancer. Also in lung cancer, dual inhibition of both VEGFR and EGFR with the combination of apatinib and gefitinib in the first-line treatment of patients with advanced EGFR mutant non-small cell lung cancer demonstrated superior progression-free survival, according to results from the Phase 3 ACTIVE trial. Findings from the Phase 3 Monarch-E trial showed that the addition of abemaciclib to endocrine therapy led to a significant reduction in the risk of invasive disease versus endocrine therapy alone in patients with high-risk, early, hormone receptor-positive, HER2-negative breast cancer. In Ewing sarcoma, regorafenib extended progression-free survival at 24 weeks compared with placebo in the Phase 2 REGOBONE study. However, the oral multikinase inhibitor failed to meet the study's primary endpoint of non-progression at 8 weeks. Quality of life, according to patient-reported outcomes, was not reduced despite treatment toxicities in those with ovarian, primary peritoneal, or fallopian tube cancer treated with niraparib versus placebo, according to a sub-analysis of the PRIMA trial. For more coverage of the 2020 ESMO Virtual Congress, please be sure to visit OncLive.com. We are here with Dr. Priyanka Sharma, who is a professor of medicine at the University of Kansas Medical Center, to cover the biggest breast cancer studies that are being presented at this year's ESMO Congress. Hi, Dr. Sharma. Thank you so much for being here. How are you doing today?
I'm good, and thank you for the invitation. It was a really exciting ESMO this year.
Oh, good. Well, I can't wait to hear about all of these data that we're going to discuss in more detail. So how about if we dive into the ASCENT trial first? This has been a highly anticipated trial in the breast cancer community and is exploring sacituzumab govitecan compared with physicians' choice of treatment in patients with previously treated metastatic triple-negative breast cancer. So could you share with us the details of this agent and what the results have shown from this trial?
So, as you said, this was a highly anticipated study, and we were all eagerly waiting to see the details of the data. So, this is an antibody drug conjugate that is directed against TROP2 and was recently approved in the United States in spring this year for patients with previously treated metastatic triple negative breast cancer. So, the ASCENT trial randomized a little over 500 patients to sacituzumab govitecan or treatment of physician's choice, which was a menu of clinically used chemotherapy agents in this setting. It enrolled patients that had been previously treated. Two patients had received about 4 prior median treatments for metastatic disease. And the trial showed really remarkable improvement in progression-free survival from 1.7 to 5.6 months, and also, more importantly, improvement in overall survival from 6.7 to 12.1 months. In a metastatic setting, we really strive to see improvement in overall survival when new agents are investigated and introduced. The drug was fairly well tolerated. There were no new toxicity signals. Only about 5% of patients discontinued the treatment because of toxicity. Because of the time frame when the study was done, about 25% of patients had also received prior immune checkpoint blockade for treatment. So clearly, I mean, these are practice-changing results, and for patients that have access to this drug and have fit the trial criteria, that is, have received prior treatment for metastatic disease, this now represents a new standard of care for our patients.
That's perfect. And what else do you think the future holds for sacituzumab govitecan, and where else would you perhaps like to see it explored in breast cancer?
So, of course, we would like to see it studied earlier in the paradigm of treatment for triple negative breast cancer. And personally, I would also like to see some combination studies that evaluate this agent with other drugs that are active for metastatic triple negative breast cancer, like immune checkpoint blockade and drugs targeting PI3 kinase AKT pathway. Of course, evaluation in other breast cancer subtypes is also critical. In fact, a TROPiCS-02 randomized study is evaluating sacituzumab govitecan against treatment of physician's choice for patients with hormone-positive breast cancer in the similar setting, like extent in previously untreated patients. So we look forward to results of that trial.
These are very exciting data, so thank you so much for highlighting this trial. I also want to also stay in the triple negative breast cancer realm. We're getting a survival analysis of the JEPR-OCTOR trial. That's of neoadjuvant chemotherapy of IDD-EPC versus weekly paclitaxel, liposomal doxorubicin, and carboplatin in high-risk early disease. So could you highlight the findings from this analysis?
So JEPR-OCTOR was a neoadjuvant trial that compared dose-dense epirubicin, cyclophosphamide, and taxane to a cyclophosphamide-free regimen of weekly carboplatin, liposomal doxorubicin, and a taxane. So the PCR results for the trial have already been published and showed similar PCR with two regimens across the subtypes. So this ESMO, we saw survival results at a 3.5-year median follow-up. And what the trial showed that in patients with triple-negative breast cancer and HER2-positive disease, there was similar survival with the two regimens. However, in patients with estrogen receptor or hormone receptor positive disease, the traditional cyclophosphamide-based regimen was superior to the weekly carbo, liposomal doxorubicin, and the taxane regimen. So the clinical implications of these results are unclear because the most commonly used regimens for patients with hormone-positive disease, at least in the current era, are ACT or docetaxel cyclophosphamide, and both of those include cyclophosphamide. And it's not surprising that these results demonstrate what they did, because we've previously seen from an NSCBP trial that cyclophosphamide perhaps is important for our regimen, especially for patients with hormone receptor positive disease.
Thank you so much. Now, we cannot talk about triple negative breast cancer without mentioning immunotherapy. So the Impassioned, yes, the Impassioned O31 and Impassioned 131 data were released at this year's Congress. What are your thoughts on each of these studies and the impact of their findings?
Sure. So let's first talk about the two trials in the metastatic setting. So we also saw updated and final survival analysis from the Impassioned O30 study, which was nab-paclitaxel with or without atezolizumab. And at this report, we see a 7.5-month improvement in overall survival in patients with PD-L1 positive disease with the addition of atezolizumab to nab-paclitaxel. Because of the statistical design of the trial, there was no formal statistical analysis presented, but we would all agree that 7.5-month improvement in overall survival is clinically meaningful. So we also saw the results of Impassioned O31 study, which was similar design to the nab-paclitaxel study, but instead of nab-paclitaxel, used paclitaxel as a chemotherapy backbone and studied addition of atezolizumab or not. And the study was important because in several places around the world, either nab-paclitaxel is not available or is not approved for treatment in first-line setting for patients with metastatic breast cancer. So surprisingly, though, the results of this study was quite divergent from what we saw with the nab-paclitaxel study, with no improvement in progression-free survival or overall survival with the addition of nab-paclitaxel, with the addition of atezolizumab to paclitaxel. So we're also trying um, to understand these divergent results, and perhaps it's the steroid use that comes with paclitaxel that we don't have to do with nab-paclitaxel that contributed to these results. A slight difference in trial population, the size of the trials. So it's quite unclear why we see these divergent results. I personally don't think it's just the steroid use, because we do see in other cancer types like lung cancer where steroid use hasn't really impacted the efficacy of immune checkpoint blockade when it's added to chemotherapy. But at the end of this, what we can say is, if one is to use nab-paclitaxel for patients, if one is to use atezolizumab for patients with PD-L1 positive metastatic triple-negative breast cancer, the right taxane partner is nab-paclitaxel, and the combination of paclitaxel plus atezolizumab should not be used. We would favor using a combination of nab-paclitaxel and atezolizumab.
Very interesting points. Thank you for highlighting those.
So at the same time, we also saw results from the neoadjuvant trial, which were also highly anticipated because we had all seen the press release earlier in the summer for that trial. And this was the Impassioned O31 trial. All the numbers are just off by one digit. So and this was a neoadjuvant trial that evaluated the addition of atezolizumab to a standard anthracycline, cyclophosphamide, and nab-paclitaxel chemotherapy backbone. It was a randomized study, and the trial showed that addition of atezolizumab to this chemotherapy backbone statistically significantly improved the PCR rate from about 41% to 57%. And this improvement in PCR rate was seen in patients with both PD-L1 positive disease and PD-L1 negative disease. And we're starting to see that in metastatic trials. The efficacy of immune checkpoint inhibitors seems to be more dependent on PD-L1 expression, but in earlier stage setting, the benefit is seen regardless of PD-L1 status. Also, we saw greater magnitude of benefit for patients with lymph node positive disease, and this is similar to what was noted in the pembrolizumab KEYNOTE-522 trial. The improvement in PCR did come at cost of some toxicity. 15% of patients had grade 3 or more immune-related side effects, and about 13% required steroids for management of immune-related side effects. We obviously were all comparing and contrasting these results to KEYNOTE-522 trial, which evaluated pembrolizumab with a 4-drug chemotherapy backbone as opposed to a 3-drug chemotherapy backbone. And the absolute PCR reach with chemoimmunotherapy was a little bit higher in KEYNOTE-522, probably because of the contribution of the 4th drug, carboplatin, to the PCR rate. Obviously, we're eagerly awaiting survival analysis from both of these trials. It's nice to see PCR improvement, but ultimately, what we are waiting to see improvement is in RFS or OS setting. Another question that comes up is, now that we see the results from the 2 metastatic Impassioned trials, is the neoadjuvant trial used nab-paclitaxel as a taxane backbone. Would one see similar results if the neoadjuvant trial had included paclitaxel instead of nab-paclitaxel in its backbone? So very encouraging results, and we're all enthusiastic to see it. But like always, a positive trial raises more questions that we will strive to see answers from over time.
Thank you so much. It is very interesting to see all of these trials, whether positive or not, but all the questions that they do bring up, and that I'm sure with longer follow-up and additional research we'll be able to answer.
And the immune checkpoint inhibitors are new kids to us in the breast cancer community, and have significant financial toxicity. So, thus the greater scrutiny in terms of, who benefits and who needs to do all our patients need it. And it's a pretty long treatment duration, because both of these trials included adjuvant components with immune checkpoint blockade to complete a year as well.
Very good point. Thank you so much. So I'm going to move on into hormone receptor positive breast cancer. So here, the combination of ipasertib and paclitaxel has some primary data in patients with PIK3CA, AKT1, PTEN altered disease. This is from cohort B of the phase 3 Opportunity 130 trial. Could you discuss the importance of these data?
So the Opportunity group of studies is assessing the AKT inhibitor ipatasertib in combination with the taxane in different cohorts. So the cohort B, which was presented at ESMO, is the cohort of patients with hormone receptor positive disease. We're awaiting data on other cohorts that include patients with triple negative disease and triplet combinations. So what was presented was results that compared a taxane versus addition of ipatasertib to patients that have hormone receptor positive advanced metastatic breast cancer, and the tumors showed PI3 kinase AKT PTEN alteration. So we did not see any progression-free survival improvement with the addition of ipatasertib to taxane in this setting for patients with hormone receptor positive disease. These findings are consistent with what we saw from Beach study last year, which used a different AKT inhibitor, capivasertib, in a similar patient population. And as the authors concluded, I think it is becoming evident that for patients with hormone receptor positive disease, the right partner for AKT inhibition is endocrine therapy, and you kind of need that endocrine blockade for drugs in this class to work. And of course, there are large registration trials that are assessing AKT inhibitors in combination with endocrine therapy in patients with advanced hormone receptor positive breast cancer.
Absolutely. Thank you. So, regards to CDK4/6 inhibitors, there's a couple of studies reading out this year with abemaciclib. So, how about we first touch on the data with this agent in the high-risk early setting, if you could highlight those intriguing results?
Of course, yes, the Monarch E study was presented by Dr. Johnson in the plenary, in the presidential plenary. And again, these were eagerly awaited results given the press release that we saw earlier a few months ago. So this was an adjuvant trial for abemaciclib in patients with high-risk hormone receptor positive breast cancer that had completed their other systemic and local therapy. The trial included patients with either N2 disease or N1 disease if they qualified based on other high-risk features. And the intervention was addition of abemaciclib for a year, along with the standard endocrine therapy. The trial is reporting at a median of about over 15-month follow-up and shows an improvement in invasive disease-free survival and distance metastasis-free survival with the year of abemaciclib, with an absolute improvement in the range of about 3.5%. So you can't talk about Monarchy without mentioning Palace, which was also presented at ESMO by Dr. Mayer. And similar trial design, but a different CDK4/6 inhibitor, perhaps a slightly different trial composition with a little bit more lower risk patients, but assessed palbociclib, another CDK4/6 inhibitor in Palace, failed to show an improvement in outcome with the addition of palbociclib to endocrine therapy. There was a very high drug discontinuation rate in Palace. About 45% of patients discontinued the drug, as opposed to what we see in Monarchy. At the time of reporting, 16% of patients had discontinued the drug. So, of course, these results are exciting, and the discussion is the magnitude of benefit versus the duration of treatment, the toxicity and the cost. I have to say the toxicity was fairly well managed in Monarchy, and drug discontinuation rates because of toxicity were low. But of course, it's an year commitment, and we do want to see longer follow-up from both of these trials. Both of these trials reported quite early for an adjuvant trial, and we're capturing all of these early events for patients with really high-risk hormone-positive disease. But I think it opens the door for us to add additional agents in adjuvant therapy for patients with hormone receptor positive early stage breast cancer since the advent of aromatase inhibitors, more than almost a decade and a half ago. We really haven't had new drugs that have entered this space. So obviously exciting for our patients.
Thank you. And I'm glad you brought up the point of adding additional agents. That could be really interesting as well.
Yes.
Now, in the metastatic setting, we have the next Monarch trial that's looking at the final overall survival results of single agent abemaciclib or in combination with tamoxifen in patients with HR positive, HER2 negative metastatic disease. So, what do you think that these data tell us about the agent overall and its use in clinical practice in this setting?
What these updated results showed that abemaciclib does have monotherapy activity in patients with pretreated metastatic advanced hormone receptor positive disease. And the trial was interesting that although it did not show any improvement in progression-free survival, we saw improvement in overall survival with the combination of tamoxifen plus abemaciclib compared to the monotherapy. And in terms of putting it into context with our current practice, typically CDK4/6 inhibitors we're employing earlier in the setting of our metastatic journey, first line setting, and at the most second line setting. So the clinical implications for these results uh, are a little bit hard to put in context, but it does tell us that patients who've had prior resistant to tamoxifen, which is what was the trial criteria, a large fraction of patients had prior resistant to tamoxifen, that adding a CDK4/6 inhibitor can reverse this. So from that aspect, it is interesting. And if there is a patient that absolutely cannot tolerate or take any endocrine therapy because of contraindications, comorbidities, or what have you, that monotherapy can be an option with single agent abemaciclib.
Thank you so much. You've been given so much incredible insight on so many studies. I'd love to see if there is any other additional research being presented at this year's meeting or any abstracts also that you might be authored on that you would like to highlight.
So I would like Solar One presented updated overall survival, and Solar One assessed fulvestrant with or without an alpha-specific PI3 kinase inhibitor, alpelisib. And we've seen the PFS data that have been published already. So the overall survival data were presented. And there was an absolute about 7-month improvement in overall survival with alpelisib compared to fulvestrant, and also delay in initiation of first chemotherapy with addition of alpelisib. This improvement did not reach statistical significance as per the statistical boundaries set by the trial design. But one would say that a 7+ month improvement in overall survival is quite clinically meaningful. So it was nice to see that the drug is actually not improving just PFS, but is providing clinically meaningful improvement in overall survival.
Dr. Sharma, thank you so much for taking the time out of your busy schedule to talk with us all ESMO stuff this morning. We really appreciate your time.
Thank you so much, and thank you for the invitation.
We are here with Dr. Yelena Janjigian, who is an associate professor and chief of the Gastrointestinal Oncology Service at Memorial Sloan Kettering Cancer Center, to discuss the biggest gastrointestinal cancer studies that are being presented at this year's Congress. Hi, Dr. Janjigian. Thank you so much for being here today. How are you?
Oh, I'm doing great. Thank you. It's a pleasure to join, and a bittersweet moment for us in upper GI because it's such a huge year at ESMO 2020, and we would love to be all together in Madrid celebrating, and we're doing this virtually, but nonetheless, this is an exciting moment. The presidential symposium just concluded, and there were 4 oral abstracts, all in upper GI, and this is unprecedented day, and I just even wanted to take that moment to acknowledge the patients, their caregivers, and also our incredible community where we of researchers coming together across the world, making such a huge difference for our patients.
I'm so glad you said all of that. It really is an exciting Congress, and I really hope that next year we're in person and not virtual, but there's a lot of great data overall that are being presented. I'd love for us to kick off with the results of Checkmate 649. This trial is evaluating nivolumab plus chemotherapy versus chemotherapy alone in frontline advanced gastric cancer and gastroesophageal junction cancer and esophageal adenocarcinoma. So could you please share some background to this study and what the results show?
Sure. Checkmate 649 is a global phase 3 study, which I was fortunate enough to lead and serve as a coordinating PI for. in the United States, we looked at combination of chemotherapy plus immunotherapy in patients with adenocarcinoma, both esophagus, G junction, and stomach cancer. And this was a first study of its kind to show benefit for addition of immunotherapy or any targeted agent to chemotherapy in HER2 negative setting. So really changing the treatment for patients with adenocarcinoma. So in a way, this was a very lucky day for our patients, as the presentation at ESMO 2020 by Dr. Marcus Mueller was recently concluded, and it shows a strongly positive study. This was a study that included patients from Asia, mostly from China, the larger population of patients, but also Japan, the United States, and South America, and other parts of the world. Patients were randomized in a one-to-one fashion to receive FOLFOX plus or minus nivolumab, and we demonstrated overall survival benefit with a hazard ratio of 0.71 in patients irrespective of PD-L1 status. So although patients of all PD-L1 status were enrolled, the primary endpoint of the study, the power of the study, was for patients with high PD-L1 expressors, defined as a combined positivity score or CPS score of greater than 5 or 5 or more. And so both the primary endpoint for PFS and OS in overall population and in CPS greater than 5 population was met. Interestingly, the CPS 5 population represented a large proportion of the patients, suggesting that the study selection and the way we enrich for patients for first-line setting is very important, and highlighting the importance of considering immunotherapy in first-line setting, and it will likely be the new standard. It will be under review by the FDA and other regulatory authorities. What's also very refreshing about the study is, for the first time, esophageal adenocarcinomas were included with G-junction and gastric adenocarcinomas. And I strongly believe the days of adenocarcinoma being connected to squamous of the esophagus are over. Biologically, adenocarcinoma of the esophagus is similar to the G-junction adenocarcinomas, not to the esophagus squamous cell cancers. So, the regimen was well tolerated. FOLFOX is very easy to give. Most of the oncologists in the US and all over the world use it. And the other sobering statistic about the study is only up to 30 to 40% of our patients in the study CheckMate 649 went on to receive second or third line therapy. What does that mean? I think there was this pause during the live session. The discussant, Dr. Smith, appropriately highlighted that this is the real world of approaching gastric cancer and esophagus cancer, and unfortunately represents exactly what the published literature shows. So we did not somehow underestimate the percent of patients who got second-line therapy. This is what happens. And once again, when we're deciding what the indication of immunotherapy should be and which patients we should approve it for, you need to consider, one, that majority of the patients benefited, a majority were CPS 1 or greater or CPS 5 or greater. And two, for the patients that were, so in other words, you would have to wait for a long time for the patients to be tested to then decide whether or not to use immunotherapy in first-line setting. And two is that, some patients who did not get immunotherapy in first-line setting may not get a second chance to get it in second or third-line therapy setting, as unfortunately at this point still, and we can talk about at a different time, what are the factors contributing to, very a small subset of patients getting any second-line therapy, but that's the reality. So that was very interesting data from CheckMate 649. Obviously, puzzling, putting in context with previous Keynote 62 data. And again, we can talk about the nuances of that. And obviously, Keynote 62 was disappointingly negative, which was also a first-line study. But, nonetheless, in adenocarcinoma, FOLFOX nivolumab will likely be the new standard in stage 4 disease. The final manuscript is in preparation now and will be submitted and published shortly, and so that will be an important milestone as well. Another study that was presented, so remember, Checkmate 649 was all adenocarcinoma, mostly outside of Japan, some Asian population, but mostly Chinese from Asia. What we know about the biology of adenocarcinomas is the Japanese patients tend to do the best, and Koreans and the US and the Western patients have a more aggressive biology. And interestingly, the patients from China, mainland China, behave more similarly to the West population as opposed to the Japanese population. So talked about Checkmate 649. What about Attraction 4? Well, Attraction 4 was also a first-line study looking at combination of S1 and oxaliplatin, capecitabine and oxaliplatin, which is the regimen accepted in Japan, with nivolumab. And what's interesting, although both the PFS endpoint was met, progression-free survival, and the response rate was clearly higher with chemotherapy plus nivolumab, the primary endpoint of overall survival was not met. What's also interesting is that in Checkmate 649, for the first time ever in the experimental arm, irrespective of PD-L1 status, in this global population, we thankfully cleared the median overall survival of 12 months. This was the first study ever in HER2-negative disease to show a median overall survival that was above a year in an experimental arm. Contrasting with Attraction 4, the median overall survival, irrespective of experimental or standard arm, was 17 months. Again, highlighting the difference in patient population and questioning whether or not we should be still using OS as the primary endpoint in Japanese studies, particularly since the majority of our patients who are reported from Japan receive second and third line therapy where nivolumab is routinely used in that practice. In other words, for OS analysis, you can imagine there's a lot more confounding variables. In certain diseases such as colorectal cancer and breast cancer, PFS is a commonly used endpoint in primary study. And so that's something to debate over next several months, both in academic community and certainly for the regulatory authorities, but an interesting discussion point.
Thank you so much. Now, there is one more nivolumab trial I'd definitely like us to mention. That's Checkmate 577, adjuvant nivolumab being explored in resected esophageal or gastroesophageal junction cancer following neoadjuvant chemoradiation. So we knew from a press release that the PD-1 inhibitor improved disease-free survival, but what do we know now with the full findings?
So the meeting today was also very exciting for esophageal patients as well, and doctors who take care of esophagus cancer. The adjuvant nivolumab data showing disease-free survival benefit is the first trial of its kind in resected esophagus cancer, where patients with persistent disease, despite standard of care chemoradiation, received adjuvant nivolumab or placebo. And there was a statistically clinically meaningful disease-free survival benefit, suggesting that this treatment needs to be considered as standard of care if we want to reduce chances of cancer recurrence. Now, in most trials, overall survival is the gold standard. So this degree of disease-free survival benefit and hazard ratio is clinically meaningful. It will help us treat our patients and approach them into clinical practice. The only question remains is how do we interpret this data in the setting of patients who received other neoadjuvant therapies other than chemoradiation. Claudin-4 is commonly used in Europe, for example, and radiation therapy is avoided in certain situations. Is this enough of a signal to use adjuvant nivolumab irrespective of the type of therapy the patient received in a preoperative setting? And I believe biologically the answer is yes. what's important to highlight is that the patients who were enrolled on this study, by definition, had relatively chemotherapy refractory disease. In other words, they had chemoradiation and then had surgery and had persistent node positive or advanced T stage disease. So if you have a flawed patient who received 4 cycles of flawed or even 8 cycles of neoadjuvant or preoperative flawed and has a persistent T3N2 tumor, this potentially adjuvant nivolumab, and again, the decisions will be made on the regulatory authority level, but this could be a new standard for those patients.
Thank you so much. Those are some really excellent points, and I love hearing how this is going to be impacting clinical practice as well. Keynote 590 was another immunotherapy trial, but this time evaluated pembrolizumab plus chemotherapy versus chemotherapy as frontline treatment in patients with advanced esophageal cancer. So could you discuss the significance of these data and what sets this trial apart, or how do we compare it with Checkmate 649, for example?
That's a great question. So Keynote 590 looked at patients with esophagus cancer. And unlike Checkmate 649, both adenocarcinoma and squamous tumors were included. Majority of the patients were squamous cell cancer, but about a third of the patients were adenocarcinoma. And once again, the statistics were a bit more complicated, looking at CPS greater than 10 as the primary endpoint, and then looking at all comers. And even though CPS greater than 10 was the primary endpoint, the groups for randomization were not stratified by that endpoint. So there may be some disbalances in chemo IO or pembrolizumab combination versus chemotherapy. What's reassuring, however, is that once again it was a positive study, and in adenocarcinoma subgroup of esophageal patients that were included as well, sort of pair well with the adenocarcinoma of esophagus subgroup that was included in Checkmate 649. In other words, really reassuring, I think, clinicians to say that, okay, first-line therapy does have legs in esophagus cancer. It's not just it's not just gastric and G junction tumors that carry the benefit, and that we really should continue to use and design our trials to include adenocarcinoma esophagus patients in first-line studies. How does the squamous cell histology translate? Well, we know that biologically squamous tumors have more mutations, and typically, and even in second-line studies, certainly for indication, both in second-line, immunotherapy trials from BMS and Merck, have the squamous cell cancers have greater benefit from immunotherapy, and so it's likely that the majority of Keynote 590 benefit, especially when you're looking at CAPE-CIS backbone or 5-FU-cisplatin backbone, is driven by squamous cell cancers, and particularly for PD-L1 CPS greater than 10. And so, the only challenge will be what backbone to use. Are you really convinced or are we going to be forced to use cisplatin-based regimen in squamous cell cancer? And I hope not, because it's a very difficult regimen to give, and most of us have not used it in clinical practice unless it's in a clinical trial. And so, both, I would say, Keynote 590 and Checkmate 649 data are reassuring that immunotherapy in first-line setting in combination with chemotherapy is safe, it's effective, and is now going to be the standard.
So exciting. What a wealth of immunotherapy data across GI cancers this year.
It all came together, and it's, like I said, if we were all there together in Madrid, there would be a big, big celebration in person, but we'll have to delay it by hopefully not too long, but get together again.
Yeah,
soon.
absolutely. Specifically, let's focus in on colorectal cancer, a little bit more immunotherapy data, some health-related quality of life findings from the Keynote 177 trial in MSI high and mismatch repair deficient disease. What are your insight on these results, and how do they inform the use of pembrolizumab in this setting?
MSI high tumors, irrespective of organ of origin, clearly benefit from immune checkpoint inhibitors. Study after study has shown that. And again, Keynote 177 is important for one major reason is because it's a study that was designed just to look at MSI high cancers. In other words, it wasn't a subgroup analysis of another larger study. And once again, it shows that their survival and the quality of life is significantly improved from patients who got immunotherapy or pembrolizumab instead of chemotherapy. And so it highlights the importance of biomarker testing early on in colorectal cancer. And MSI is the first one, but not the only one. And certainly we're in the habit of testing for BRAF as well. But typically for colorectal cancer, these tests are happening later in lines of therapy. And what these Keynote 177 tells us is that you have to do it early, and you have to do it on everyone, and you have to know your MSI status, because these data will have real implications for patients and their quality of life. There's a lot of excitement about HER2 testing, and again, in later lines of therapy, but it's important to do it in early lines of therapy in colorectal cancer, because really that's when you may be able to make the most impact for your patients. We also saw data on POLE mutations in immunotherapy, and not only testing for POLE, but knowing what type of POLE mutation the patient has is very important. There are certain previously so-called variants of unknown significance actually have real therapeutic implications, and may not be so unknown of significance. And so biomarker testing early and reliably and consistently is going to be important in this disease.
Thank you so much. And thank you for driving home that point about biomarker testing and how important it really is. I do want to focus on just kind of looking at the scope of various GI cancers with data being presented this year's meeting: pancreatic, liver cancer, cholangiocarcinoma, et cetera. What are some additional abstracts of interest that the community should be informed of? Any research that you're involved with at this year's meeting that you'd like to highlight?
So, there's, so ESMO is really an exciting and dynamic meeting, and more important data is presented. If you were looking at New England Journal of Medicine, feed yesterday, there were a lot of simultaneous presentations and other tumors beyond GI. This year, ESMO 2020 will always be in my mind dedicated to upper GI, more so than other years. That was a big splash that was made in upper GI, and certainly I'm most proud of Checkmate 649 because it's a study that I helped take to completion. It's interesting. There's a lot of also, if you look at the abstracts, what's interesting is how much excitement and data is about to come. So you see a lot of interesting data and trials in progress, and you get, or not data, but summaries in trials in progress, how much work is being done in HER2 space, in gastric and colorectal, in BRAF and colorectal, in smaller subsets, by biomarker-driven subsets, both in biliary cancers, and also in pancreas cancer. So all of this work has not slowed down despite COVID, and which is, and some of it is coming back even in a larger scale, which I find very exciting and reassuring. Cancer can't wait. COVID is scary, but cancer is in some ways still much more dangerous for most of our patients. And it's important to stress continuing of research and continuing our care of our patients in the new norm that we've all starting to get used to.
Dr. Janjigian, thank you so much for sharing such valuable insight with us today during the ESMO Congress, especially taking time out of your very busy schedule. We appreciate it. And thank you so much. Have a great rest of your meeting.
It's always a pleasure to sit down with you. Thank you so much.
Thank you. That's all for today. Thank you for joining us for another great series of OncLive News Network on location. Signing off from the 2020 ESMO Virtual Congress, I'm Gina Morrow.